So welcome everyone to this SIOP hosted webinar as part of London Global Cancer Week. I'll just get started with some introductions whilst people are joining. I'm Kathy Pritchard-Jones. I'm the past president of SIOP, and this is the third year that we have run a series of webinars during London Global Cancer Week. This is our first webinar of the week, and it's focused on progress in childhood cancer data sharing, with a focus on how we can use this to accelerate research, improve care, and hopefully inform policy. We have 5 really excellent speakers who are each going to speak quite concisely for 5 minutes each and then hand over. If you've got any questions for an individual speaker, please put them in the Q&A function of the webinar link, and we will either answer your questions during the talk or we'll keep them for the panel discussion. Once we've heard the 5 speakers, we've then got 5 excellent panelists who are going to comment on what they've heard and ask some questions, and we'll at this point include some of the questions from the floor. So thank you very much again for joining. I'm going to introduce the first speaker, Professor Sam Volkelbaum, who's based in Chicago, and he's going to give an update on a project that's maybe well known to many of you, the Data for the Common Good, the Pediatric Cancer Data Commons. Over to you, Sam.
Great. Thank you so much. Really happy to come speak today about the Pediatric Cancer Data Commons, which is part of my research group, Data for the Common Good. Despite lots of improvements in how we take care of kids with cancer, obviously we need to keep in mind that many children, in fact, in some areas of the world, most children who die from cancer are never diagnosed with cancer. The keys to improving outcomes for rare diseases like childhood cancer are collecting, aggregating, and democratizing access to high-quality data. So one of the things I've been working on for the last 10 years is how to deal with this perfect storm, where we have rare diseases, data that are siloed, manual processes to extract the data, a pervasive lack of data standards, all in the difficult problem of trying to answer hard research questions. So Data for the Common Good is here to build communities, platforms, and ecosystems that maximize how we use data to drive discovery and improve health. We do this through making data highly accessible and usable, making sure that it reflects the diversity of our patients, making it easy for people to do the right thing and use data responsibly, to build community around how we use data, and to drive impact to use data to its maximum potential. The Pediatric Cancer Data Commons is made up of several independently acting consortia. Most of our consortia are listed here, and in most cases, we help run these different pediatric cancer consortia. These are international initiatives with stakeholders from all over the world. In addition to the Pediatric Cancer Data Commons, we have a clinical trials matching platform that we've built, along with several other new disease areas that we're working on, all in rare diseases. We believe in a big tent philosophy, where we want as many people to come and join us as possible. So this doesn't leave us with just academic medical centers. We're very intent on bringing in cooperative groups, pharmaceutical companies, and other industries, as well as patient registries. And we want everybody to come to the table because we want everyone's input on the best ways to try to democratize access to rare data. We spend a lot of effort on developing data dictionaries, both through in-person and online meetings. The central problem is that many institutions will collect data according to whatever standard they want. In this example, something as simple as biologic sex, using numbers or using just uppercase letters. And that makes it very difficult, as you can see on the right, to harmonize data from different institutions. So what our group does is that we get together with all of the groups from around the world that we can, and we come to a consensus, and then we bind those consensus elements to common data elements that are in a repository. In this case, we're using the NCI's repository, but there are many different examples that you could use. This is from our website, and it shows all the different pediatric cancer areas that we're working in, along with the version of the data dictionary that we have, as well as the numbers of data contributors, the number of cases we have in the commons, as well as the number of studies in progress. In the middle are the names of the various consortia that we've helped form or that we help run. And then you can see also that we've now expanded into other rare disease areas and are actively working on those as well. All of our data dictionaries are open to the public. They're on our website. You can see the link here. And all of the dictionaries are highly annotated, and they're available for people to download and to use. And we encourage people to use these dictionaries to help drive their own data collection. The link to my slides is at the bottom of every slide. Hopefully you figured that out already. And that will include then the links to the various things I'm showing you. We work with groups all over the world, and we've been able to conform to GDPR and UK data protection, HIPAA, and any other regulatory compliance needs. We have data sharing and use agreements with 40 different countries, and we have users all over the world who are now leveraging the data for their own studies. Our governance is set up such that the disease consortia each act independently. And then on the right, our team is more of a service providing team. We're not allowed to give out data unless it's on behalf of one of the consortia. And then at the top, we have our international advisory groups, Scientific Advisory Committee and External Advisory Board, an Adolescent and Young Adult Research Council, and just launched last week a lived experience advisory panel made up of parents and patient advocates. We have a publicly available portal that anybody can use. It has access to all the data we have in the Commons to study in aggregate. Here's a search over neuroblastoma patients looking for stage 1, 2, and 3. You can save your searches and come back to them, and you can even do things like generate survival curves. We're tracking our publications, obviously, as one of our measures of impact, and we have many projects in progress, and we have now over 90 publications that can be related to data that are in the Commons. In addition to the AYA and adult and pediatric cancer we're studying in the middle, we are also studying cancer predisposition syndromes, and more recently, we're getting involved in studying late effects and survivorship. A couple words about our clinical trials matching platform. The problem we're trying to tackle here is that patients who have refractory or relapsed disease are difficult to find new therapies for. And in general, these patients often go on holding chemotherapy while we look for a clinical trial. So working with the Leukemia and Lymphoma Society, we've developed Gearbox, which is a way to try to find a trial match for a patient within 3 to 4 days of having been identified as having refractory disease or relapsed disease. As you know, clinical trials are not standardized. These are just 2 pages from one trial showing different types of inclusion and exclusion criteria standards and different acronyms and abbreviations. Makes it very hard to read through these protocols and to understand the eligibility. Makes it difficult for clinicians, let alone parents and families, to do the same work. So we developed Gearbox, where the extraction of inclusion and exclusion criteria are formatted for a clinician or a parent to use much more easily, and then to find eligible trials and perhaps connect with a patient navigator. The front end is open to the public. Anybody can use the platform. You just enter what you know about the patient, and then the trials which are available on the platform will sort into matched versus unmatched. So here's an example, two different versions on the left and right showing different data entry. If you click into a trial, you'll see information about the trial, how to access navigators, how to find out more information about why the trial was this particular trial was a match or a non-match. We're expanding Gearbox now with some additional funding. We're trying to include information from electronic health record systems, as well as third-party vendors and other groups that manage data about the patients, hoping to provide a much more rich list of potential trials for patients, as well as more information for patients and families to get once they have identified potential trials. So I think this is my last slide. The things that I think have made us successful is that we take a data-first approach, meaning that we spend a lot of time working on the data dictionary, coming up with a consensus model. We want to make sure that any dictionary we build will be highly specific to the needs of that particular group, but also highly sustainable as it is harmonized across many different disease areas. The autonomy of each group is important in that they can control how their data are used, but we also feel very strongly that the clinical data we collect need to be centralized and made available as a harmonized set of data. We work on change management and quality control with everything from our data all the way to our algorithms, and we want to make sure that that is very transparent to those that are using our data and our platforms. And then we spend a lot of time, effort, and resources on data governance and data provenance, making sure that we're making it easy for people to do the right thing when it comes to how they use data, that they understand the data sharing and use agreements, and that the data conform to any regulations necessary. We have about a 30-person team now at UChicago, and made up of programmers, project managers, communications experts, and so forth. And we're always looking to grow and looking for additional people that are interested in helping us with projects. We're very thankful to our funders, most of whom are foundations, in addition to the National Cancer Institute, who we've been working with very closely for the last couple of years. And of course, we're very grateful to our patients and families who've helped make our work possible. So with that, I'm going to stop and I'm going to hand it off to Dr. Greg Riemann from the National Cancer Institute. Thank you.
Greg, you're on mute. We can't hear you.
Sorry.
That's better.
Sorry about that. Can you hear me now? Sorry about that. Thanks for the introduction. And I'm pleased that I'm going to be able to provide some information on the NCI's Childhood Cancer Data Initiative. The CCDI, the goals of the CCDI, this actually emanated from a special congressional appropriation to support pediatric cancer research. The goals and objectives were actually formulated by an ad hoc working group that was constituted by the National Cancer Advisory Board and the NCI's Board of Scientific Advisors, essentially to integrate and gather data from every child, adolescent, and young adult diagnosed with cancer, to create a national strategy for molecular characterization of cancers at the time of diagnosis to inform accurate diagnoses and treatment in the time of precision medicine, and to develop a platform and tools that would bring together clinical and research data that would improve new preventive measures, as well as hopefully shed light on new treatment strategies and opportunities. This really engaged the entire childhood cancer care and research community, clinical as well as basic science investigators, data scientists, and most importantly, patients and advocates. The types of data that were deemed essential for integrating are shown on the right. The plan was to enhance cloud computing, to link various data types, and to develop standards and tools for data interoperability, and develop a number of data repositories, as well as linked data through the National Childhood Cancer Registry. This slide just demonstrates some of the NCI-supported pediatric cancer research initiatives whose data are housed or being housed within the CCDI ecosystem. Data is aggregated across broad categories, and we hope to enable access and use to allow generation of new ideas that would hopefully result in innovative treatment strategies. Just to demonstrate briefly the ecosystem and some examples of projects, some that I'll talk about a bit later: the Molecular Characterization Initiative, the Pediatric Preclinical in Vivo Testing Program, a number of supplements from NCI-supported cancer centers with clinical and genomic data, as well as the Childhood Cancer Survivor Study. These data sets come in, are curated, are submitted through the NCI's CRDC, the Cancer Research Data Commons, are then harmonized and aggregated through a number of knowledge databases, the Childhood Cancer Data Catalog, and the Molecular Targets platform as examples. This is just an example of the screenshot from the CCDI hub on the Childhood Cancer Data Catalog, which is essentially an inventory of pediatric oncology data resources, some 317 unique data sets, and it was recently updated, and there are ongoing updates and additions to this on a regular basis. Some of the other resources can also be found on the hub. The Childhood Cancer Clinical Data Commons, derived from the PCDC that you just heard about, the Molecular Targets platform, and other knowledge databases. The National Childhood Cancer Registry is a rapidly growing data resource for public health statistics. Data is collected from children, adolescents, young adults with cancer from state cancer registries, some 28 registries now involved. This expands the NCI's SEER, Surveillance Epidemiology and End Results program, and now represents about 75% of the U.S. population of patients less than 39 years of age. Sorry, there are now more than 1.8 million cases. We expect that this will actually expand to over 80% by the end of the year, and the aspirational goal is obviously to get to 100%. But it does enhance access to and use of childhood cancer treatment and survivorship data, and allows a better understanding of causes. One of the defining initiatives of the CCDI is the Molecular Characterization Initiative. This is a national strategy to provide state-of-the-art molecular characterization for every child with cancer, to define a minimum set of molecular diagnostics. Our objective is to perform standardized testing on up to or more than 30,000 children annually at no cost to patients and families, and develop a annotated biobank for future research from residual tissues. So part of this is a clinical service done within the context of a CLIA certified environment, so that laboratory results can be returned to patients and families and physicians within 2 to 3 weeks. This is just a schematic of the pipeline. The NCI-supported studies from which specimens are obtained go through the pipeline. The clinical sequencing includes whole exome sequencing, Archer fusion analysis, the EPIC methylation array, and then clinical and demographic data, which is both stored in the ecosystem, as well as I mentioned, clinical results being sent back to the patient's institution where they're receiving care. Specimens that are remaining are biobanked, and we are actually now in the process of developing a research-grade characterization, which will include whole genome sequencing, as well as RNA-seq and single-cell RNA-seq, proteomics, and metabolomics. So this was launched in 2022 in partnership with the Children's Oncology Group, and since it was started in stages, we began with CNS tumors, advanced to soft tissue sarcoma, then rare tumors, more recently high-risk neuroblastoma. Soon we'll be adding Ewing sarcoma, as well as osteosarcoma in discussion, and relapsed tumors. So as I mentioned, results are returned within 2 to 3 weeks. There are now more than 5,000 patients that have been enrolled, primarily from the United States, but also from Canada, Australia, and New Zealand, giving the representation of institutions in the COG. As far as just overall results for the first 2 years, I just want to demonstrate the somatic single nucleotide variants and copy number variants in the majority of tumors. But most impressive here is the percentage of patients enrolled who have demonstrated germline variants, and particularly in the group of patients with rare tumors, and this will result in some additional studies going forward. As I mentioned, we plan to add Ewing sarcoma and also to expand to adolescent and young adult patients outside of the COG as part of our coordinated pediatric, adolescent, and young adult rare cancer initiative, which I'll mention briefly. We're in the process of prioritizing diseases for the research characterization. To date, 30% of the patients have had their diagnoses refined as a result of these genomic studies. 30% of patients have received targeted therapy based on genomic findings. And these results are now contributing to study eligibility criteria in the COG in medulloblastoma, as well as in high-grade and low-grade gliomas, and in high-risk alveolar rhabdomyosarcomas in patients with MyoD1 and P53 mutations. We've also demonstrated a number of targetable pathway alterations in H3K27 mutated diffuse midline gliomas, in the MAP kinase pathway in FGFR1, as well as FGFR4 in fusion-negative rhabdomyosarcoma. The Coordinated Rare Pediatric and Young Adult Cancer Initiative is an attempt to actually conduct longitudinal epidemiologic cohort studies, essentially natural history studies, and include evaluation of potential genetic predisposition. These rare cancers defined as those that occur in less than 2 million patients at risk per year. Collecting genomic information through the MCI, the molecular characterization initiative I just talked about. We've put together already an international group to come up with critical common data elements that will be collected across all cancer diagnoses and additional elements for select cancers. Included will be family history and some history on pre-diagnosis exposure data, as well as treatment data and social determinants of health data. We're looking at possibly developing a navigation system, as well as organizing a series of virtual molecular tumor boards. This will actually allow longitudinal evaluation of patients, hopefully natural history studies with data that will be hopefully viewed as fit for purpose for regulatory purposes for new agents that might be developed in these very rare cancers for whom randomized clinical trials may be impossible. The really exciting thing here is our opportunity to work collaboratively and in cooperation with our European partners through the EU-US Task Force on Cancer Health Cooperation. This is organized through the NCI and the White House Cancer Moonshot and the EU Beat Cancer Plan. 2 projects were selected, fortunately one a pediatric project. So are working together to develop the longitudinal cohort studies with our European partners continues. And with that, I just want to leave you with resources and information, and we would welcome your participation and engaging with us. And thank you for the opportunity here. And I'd like to pass the discussion on to Dr. Brenda Mallon from the Institut Gustave Roussy. Brenda.
Thanks, Greg. I think you may have to stop sharing so Brenda can start. Oh, I think you just started.
Can you see my screen?
Not yet, Brenda. We can see you.
It's not so bad.
That's it, Jess. It's coming up. Thanks.
It's coming up.
Okay. So thank you very much. I'm going to present the progress in estimating the impact of tumor stage at diagnosis on childhood cancer survival in sub-Saharan Africa. So this, is it moving down? Sorry, you're still seeing the first screen, are you?
Yes, your title slide.
Okay.
It's moved, yes.
Okay, thank you. Let me just get that up. So the with the Global Initiative for Childhood Cancer, the announcement of 60% survival for children by the year 2030, this underlies the need to scale up hospital registries. And so I'm afraid I'm not able to. Okay, sorry, my two screens are not functioning together. So this underlined the need to scale up hospital registries in low and middle income countries where the evaluation of survival for GIC is very complicated. So improving registration was very important. And with this in mind, the French African Pediatric Oncology Group, the GFOP, which supports the establishment of units in Africa, the idea and the objective of this association is that children in Africa will be treated by African staff in an African setting. So in 2016, we established a childhood cancer registry, which collected data from different units that were spread right across from North Africa right down to Madagascar. So today there are about 13,000 children registered in the database from 21 centers. And as you can see, when we started in 2016, we had 10 units, and progressively we have been adding units right up until the most recent, which was in Congo and Brazzaville, and also Bergerville, which is the second unit that has opened in Ivory Coast in Abidjan. If you'd like some more information about the GFOP, that is our link to the site. So we're collecting data. GFOP has been collecting data since the year 2000, but this registry is collecting data from all children coming in to the different hospitals. And so we also at that time wanted to see the feasibility of using this data so that it would actually be able to use locally or on a national level, but also internationally for comparative studies. And we ran a study which was published in 2023, looking at the implementation of staging guidelines and the adaptation of these international stage guidelines in this setting, in a low and middle income country setting. So this was published, as I say, in 23. So to do this study, we extracted data from 7 different units, and we had 2,133 children that belonged to the 15 cancer types that are studied by the guidelines. We were not able to stage 4 of the cancer types. We were not able to stage acute lymphoblastic leukemia, nor were we able to stage central nervous system tumors. Because of the CNS information that was not available, and also the morphology in the central nervous system tumors. However, we were able to, for the 11 other cancer types, we were able to stage 89% of these cases. And these are very positive results and compare very favorably to other studies that were carried out to evaluate feasibility of the Toronto guidelines. One study that was run in sub-Saharan Africa looked at 4 different cancer types on data from a population-based registry in Abidjan, in Kampala, and in Harare. Also in the Australian study, which was also a feasibility study of the implementation of these guidelines, they were able to stage 88% of the cancer types. And the more recent JAR pilot study in Europe, which looked at the staging of nephroblastoma and neuroblastoma, and they were 95% of these cases were staged. So when we wanted to look at the overall survival of the cancers, what we noticed was the very high percentage of stage 3 and stage 4. 34% of retinoblastoma cases had metastatic disease, 32% of nephroblastoma had metastatic disease. But we were very encouraged by the results with 90% of Hodgkin's lymphoma overall survival at 1 year, Burkitt's lymphoma 42%, retinoblastoma at 60% at 1 year, and nephroblastoma 71%. What we also noticed was that survival was better for localized disease compared to metastatic, which is what we would have expected, and it was very poor survival for unclassified cases. So in conclusion, this GFOP centralized database has allowed the analysis. So collecting data and compiling data has allowed us to be able to look at this and also to look at overall survival, which is really in keeping with the global initiative for childhood cancer. Often these databases that are hospital-based are the only information that is being collected in the country or in a region on childhood cancer. So it is very important to encourage that this data is actually of quality, which we work a lot in looking at the quality of our data, and also that it will help in other studies in these different settings. We were able to demonstrate that it was possible to accord Toronto stage guidelines, but we were not able to stage the two most frequent cancer types in high-income countries, the acute lymphoblastic leukemia and central nervous system tumors. And this is something that we were concerned about. So direct access also to clinical records and medical expertise is something that can help in data quality, and therefore we support this work and think that it is very important to continue with this work for the GFOP. So thank you very much. And I now pass you over to Eva Steliarova Fouché, who is going to speak to you about population-based cancer registration. Thank you very much.
Hello, I'm Eva Steliarova Fouché, and I'm grateful to join this session and speak briefly about the Child GICR collaboration. GICR in the title stands for Global Initiative for Cancer Registry Development. Since 2010, GICR provides support to regional partner institutions in the 6 GICR hubs to develop population-based cancer registries. Using this GICR infrastructure and the IARC expertise in coordinating international studies on childhood cancer, we teamed up with the St. Jude Children's Research Hospital in 2020 to develop a long-term collaboration focusing on registration of cancer in children. Combining our goals, expertise, and resources, we are now in the 5th year of collaboration around 3 work streams: implementation in countries, development of educational program, and conduct of topical research studies. Child GICR, by this initiative, supports the WHO Global Initiative for Childhood Cancer, which mobilizes resources and political will across the world to improve the outcomes, especially in low resource settings. Strengthening of cancer registration is one of the pillars of cure-all framework of the Global Initiative for Childhood Cancer. Because cancer is rare in children, it has long been disregarded in cancer control, although targeted and precise measurements are particularly important for the rare diseases such as childhood cancer. Data on childhood cancer patients are collected in hospital-based and population-based cancer registries, and their cooperation is important. Child GICR program is envisioned to support population-based cancer registration in particular, because monitoring and evaluation of cancer burden involves several structures requiring sustained governmental support, often on national level, and therefore it is more challenging to maintain than a hospital-based registry. Based on the largest collaborative study of 308 population-based cancer registries, comparable data on childhood cancer incidence were available for less than 14% of the world child population. It is therefore not surprising that the estimates of the annual number of new cancer cases varies considerably, along with the assumptions adapted to generate these estimates. For example, Ward and colleagues assert that on a global scale, as many as 43% of cases that occur in a population are never diagnosed. This uncertainty around the global incidence of childhood cancer is one of the foremost reasons why investing in population-based cancer registries is important. Developing a population-based cancer registry is a long-term, open-ended and growing project, and it requires collaboration of many stakeholders. Therefore, we are starting small, working in several target countries with the local champions. We benefit from the incentive of the global initiatives while adapting to local circumstances. We also build capacity through Child GICR educational program. After having developed teaching materials for 7 topics specific to childhood cancer registration, with contribution by 20 trainers in 2021, we are running training courses in different world regions so that more than 100 professionals will be trained by the end of 2024. We are conducting several simultaneous research studies, of which I present just one example. In the chart here, we can see the differences in incidence levels reflecting the adopted practice in registration of CNS tumors. Where non-malignant CNS tumors are not registered, incidence rates are lower and the international comparison is compromised. These findings will support our pledge for the need to register all CNS tumors occurring in children, whether they are invasive or not, in all cancer registries. We believe that the described activities will contribute to availability of more and better data on childhood cancer, although this endeavor requires involvement of policymakers and committed investment by national governments. More information can be found on our Child GICR website, and we would also welcome any feedback and expression of interest in supporting registration together. So that's all I wanted to say, and now I pass the floor to Sarah Charnow from WHO. Thank you.
Thank you very much, Eva. And thank you to everyone so far. It's really fascinating hearing about the different ways that data can and is being used. And I'm just going to tell you about one more way. So can you see my screen in proper presenter mode? Like everyone can see the normal screen?
Yes, but you're not in full screen. We're seeing a small on the side.
Let me see. Now?
Yes, that's better. Thank you.
Just swap it over compared to the last time. So thank you for having me. I'm Sarah. I work on the Global Observatory on Health R&D at the WHO. And I thought I'd tell you a little bit about what the Global Observatory is, and then an analysis that we've done on pediatric cancer. But yeah, let me tell you more about it. So the Global Observatory on Health R&D is a global level initiative to contribute to the identification of gaps and opportunities for health R&D, and it covers all disease areas, all R&D. So what it does is it collates and analyzes many different sources of information, including who's doing the research, such as what institutions are training health researchers, how many health researchers in a country, all the way through to what clinical trials are happening on this disease, what products are in development. So we have a huge range of data sources, which we provide a centralized spot where you can access any of it. It's all freely available. To identify what, where, by whom, and how health R&D is being conducted globally. And I've put this QR code in in the corner of some of the slides to go to the specific data or what I'm talking about. So do feel free to go to any of those to access what I'm talking about. And I thought I'd just zoom in a bit on clinical trials. So clinical trial registrations are critical to understand global R&D. And the idea of clinical trial registries actually only came about in 2000. And it's to promote research transparency and avoid duplication and research waste. And the WHO set up the International Clinical Trials Registry platform, which is where many different registries from all around the world have their data in one easily accessible place. And at the Global Observatory, we actually clean these as over 1 million records at the moment. And we analyzed these global trends in clinical trials. So where are the clinical trials happening? Who are they happening on? How are they designed? We use this to try and set national and international priorities. And I just wanted to make the case, as ever, data and metadata sharing is critical to be able to make the maximum health benefits from the data. And so to zoom in, we developed an analysis on clinical trials on cancer in children. And together with the Global Accelerator for Pediatric Formulations and the Cancer Unit at WHO, we analyzed all the pediatric clinical trials happening on not just on children, but on drugs that were used for children. So it includes adult trials as well. And we found a number of things. You can access the full report here, but I'll just give you some highlights. 28% of clinical trials are occurring in the countries which have 90% of the burden of childhood cancer. So that's a huge disconnect as to where the trials are happening and where people have cancer. And in particular, only 4% of trials are occurring in lower middle income or low income countries. And we know that access to clinical trials improves your survival rate of cancer. So already just not being able to access trials is a huge block for countries in lower middle income countries. But also the products that are developed may not even meet those needs. So if they're developed in a situation which isn't the situation in which they ultimately need to be used, that can have a huge impact. And one thing to really highlight is GAPF, along with the WHO team for the Essentials Medicines list, assessed the age appropriateness of the oral medicines in development. And only 34% of the oral medicines in development for pediatric conditions are in a pediatric friendly formulation. So we need to be able to be thinking about access and delivery really from the beginning of these. And just to give you another aspect to some of the analyses, and you can access the data from the QR code, is thinking about the new products that are coming. So currently 291 of 440 newer medicines and targets, 66% are immunotherapies, of which 48 are CAR T-cell therapies. And while the percentage of new therapeutics is increasing for the immunotherapies, the enabling measures for their necessary success in all regions of the world is not yet there. And so I just wanted to highlight, there's a huge amount of CAR T-cell therapy activity happening in the USA and China, but we need to make sure that health systems and trials are occurring in other countries so that these other populations can benefit from these new therapies. And so what's the point of data? I mean, it's always to drive change. We use the data to understand something, to go further. And so we use this data to make recommendations on product development, on how we approach product development and who should be doing what when. We also use it for advocacy for the unmet needs of the pediatric population. And really critically, I think, is prioritization. So there's limits on the funds, on people's time. And so how do we prioritize the most effective products that need to be developed for maximum health benefit to meet unmet needs? And so the GAPF, Global Accelerator for Pediatric Formulations, uses a specific structured process called the PARDO process to really identify those pediatric priorities. And Martina will probably talk about that in the panel discussion afterwards. And looking forward, we are preparing an analysis of all cancer clinical trials as well. And so trying to make this data to all trials that are happening on cancer at the moment, and what can we say from that? So I think just to end, we know that R&D on childhood cancer should place greater emphasis on product development for children and the unique biology of childhood cancers. With that, thank you. And I hand back over to the panel discussion. Thank you.
Thank you very much, Sarah, and all 5 speakers. Really excellent and thought-provoking talks. I'd like to remind the audience to keep the questions coming in on the Q&A. We've already had 2 important ones that Sam Vockelman's going to answer live when we come towards the end of the panel discussion. Now we have 4 panel discussants, 2 very eminent people from WHO. But first of all, and perhaps most importantly, I'd like to invite Susanna Tomasikova, who is herself a survivor of a childhood cancer and who works in advocacy and with Childhood Cancer International Europe to represent the patient voice. Susanna, over to you to give your reflections on what we've heard in these 5 presentations. Thank you.
Thank you very much, and thanks for the privilege being here. It's really great to obtain these insights in these initiatives, and coming from the parents, patient, and survivors community, we are more than keen and highly interested that the data are not siloed and are not landing in silos and can be reused in order to improve the research, but more in the end actually improve the quality of life within our community. I would like to come to the first 2 speakers because I would be really interesting, because when we are talking with healthcare professionals and also registries in our regional or national level, we always or very often get the questions or the difficulties with regards to sharing data, with regards to the protection. And I would be interested how the data for common goods could have be successful in order to collect data, in which extent it has to do with the consent from the patient, or in which extent it had to with the, let's say, involving all the healthcare professionals and also other stakeholders to improve and to see the advantages of sharing data. Thank you.
So Sam, I think that's a question for you, and perhaps you could also pick up on the question in the chat in your answer.
Yeah, I think they're very similar. So I thank you so much for the question. And sharing data with our colleagues in other parts of the world has always been a priority for us. We've really been successful in complying with GDPR, UK data protection, and other regulatory requirements. And the way we do that is we work with each individual institution to understand their requirements and then develop ways to comply with those. So, for instance, certain countries only allow sharing of data if all the identifiers are completely stripped out. And in those cases, there's not much we can do other than take the data, and then when we get updates to the data, we get another copy of the entire data set to replace the current set with. But many countries allow the sharing of identifiers in this so-called pseudonymized format, in which the local institution maintains a connection between that identifier and the patient. We never see that, of course, and then they can send us updates to the data as they get updated outcomes data or other information about those patients. We've worked with groups all over the world, not just in the EU and in the UK, but we have never had there's never been a case where we were not able to come to consensus on how to share data. And so we hope to continue that as we work in other countries around the world. And I'm happy to get into further details if anything else comes up. But in general, just having somebody dedicated to working with the attorneys at each institution has been critical to the success of data sharing.
Thanks, Sam. And I think Susanna was keen to get Greg's perspective on her question area as well, if he's able to come in there.
Well, I can address the issue to some extent, because most of the data within the CCDI actually originates from patients who are cared for at institutions in the US. Although many of the clinical much of the clinical trial data actually comes from patients enrolled on children's oncology group studies, which does include institutions in Canada, in Australia and New Zealand. And we have not had difficulties there. We are aware of the individual patient level data sharing issues between the US and Europe. And one of the reasons actually that our Rare Pediatric Cancer Initiative was selected by the European Commission and by the US White House was to see if we could actually develop this coordinated international registry despite the European regulations in the GDPR. So that is something that we are working on. Again, these are anonymized data, but there are identifiers which are known not to us, but to the honest brokers who have the data. So using a system called a participant index and a series of privacy preserving record linkages and APIs, so we're able to identify, or at least identify, or link, I shouldn't say identify, but link clinical data to other data, outcome data, genomic data, without actually revealing any patient confidentiality or identities. But this is something that is problematic. I think it's recognized by the European Commission as something that needs to be addressed in order to advance international clinical research collaboration and data sharing. And one of the reasons why we're so excited about being able to actually work on this project.
Thanks, Greg. And I think it's tremendous that you got that pediatric young adults rare cancers selected. I'm just going to add a comment myself to a question in the chat about ensuring that patients can't be duplicated. I think this is a question, and particularly across countries or continents, just to highlight that in Europe, there is something called the UPID, trying to give each patient a unique identifier that can be recognized across Europe. It's sort of doubly de-identified, but all these things need resources and quite sophisticated informatics as well as governance. That's just to mention that. In order to, we're running a bit out of time, so I want to keep the panel moving. Susanna, thank you very much. I'm going to move on to invite Dr. Venkat Radhakrishnan from Chennai in India to speak about his perspective on the as head of the Indian National Childhood Cancer Data Initiative, and also the director of an institute that's involved in the St. Jude global registry work. Venkat, over to yourself.
Thank you, Kathy, for this opportunity. What is quite striking here is that much of the data collection is happening in high-income countries. And when I look at it from a lower middle-income country perspective, the first is, where is the data? You have to literally enter into dusty rooms, take out files, get the data, and then ensure that the data quality is high. And the motivation to collect data is also quite less. So we have to really start from not looking at the data, but finding the data, ensuring that the data is correct and appropriate, and motivating the oncologists, the staff, the registry to, it's one of the tasks, with you are doing multitask. You're taking care of the child, you're doing academics, you're doing teaching, and for data, you need human resources, you need people, you need money. So we just did a study and showed that it's multifactorial. Unless you address all these issues at the ground level, it is very difficult to get good quality data.
Yes, thank you, Venkat. And I think Dr. Gashau in the Q&A from Ethiopia also made the point about the importance of, enabling data usage in low middle income countries where so many children are. And I think we've seen from the examples in North America and the GFAOP, French supported support to sub-Saharan Africa, that resources are, can move the needle and make things happen. I'm going to then invite Dr. Penazzato from the WHO Science Division to make some comments, and perhaps I could ask you to comment on the question that just came into the chat, which is also, what do we know about, are there any data or inventory of what medicines are available in the LMIC setting? Because obviously access to medicines is critical for treatment and any chance of cure. So over to you, Martina.
Thank you so much, and thanks for the invitation to contribute to this conversation today. I think that, as you've seen from data shared by my colleague Sarah earlier, I think the gap is there in terms of R&D, and I think that some of the discussion we're having today with regards to how utilize and untap and unlock the power of data, it's tremendously important. I think that we need to remember that a lot of the efforts that have been described today and that are evolving and expanding over time are going to be essential, not just to better understand the clinical presentation, the clinical management of childhood cancer in countries, but also to inform and better target research and development efforts. We know that, for example, to determine what are the appropriate formulation that should be utilized for the various therapeutic options that we want to have for these children is going to be critical for us to understand the age distribution and fully characterize the population we're going to target. And I think that the data collection systems we've heard today are really essential to inform that. So it's not just about monitoring safety and effectiveness of treatment, but it's also about informing policies and then informing R&D strategies. And then perhaps to add to that, I think that we've heard how some of the efforts that were presented today are already working with national governments. But I think that type of ownership of data collection systems, it's going to have to be supported and expanded further. I think we have a great momentum and opportunity with some of the cancer initiatives that are being implemented on the ground. And I think that capitalizing on those efforts will be really essential. I think at the same time, there's also enabling policies that are being designed towards using genomic data, for example, not necessarily for childhood cancer only, but more broadly for cancer and for other diseases. And so we hope those developments will also support some of the work that partners have described today and moving forward. And maybe just lastly on the point related to the availability of these drugs in countries, I mean, my colleague Roberta certainly can comment more precisely there, but there is an important gap. We know that even medicines that are in the essential medicine list aren't necessarily available on the ground. And I think that some of the initiatives that you know of are really trying to identify what these gaps are, diagnose what are the issues related to that, and then trying to really address them through a number of interventions that we hope to be able to put in place in the future. So a bit vague, but the testimony of a lot of the work that is ongoing at the moment, and that we are certainly trying to focus on moving forward. Thank you so much.
Thank you, Martina. We're 1 minute to go. I'm just wondering, I know Sam's got to go and do clinical rounds, but there's a question from him, from Susanna, about your LEAP, how you set up your patient advisory panel. I don't know if, Roberta, you can hang on a few extra minutes so we can come to you after Sam's answered that. Just to say, how did you sort of, design and set up? It's in our panelist chat about the...
Yeah, so our lived experience advisory panel has just launched 2 weeks ago. We had a great first meeting. We wanted to get patients, advocates, and stakeholders to the advocate community together, and we are going to charge the group with making sure we understand all of the ins and outs of approaching patients to access their data directly, how we use the data, how we return results to patients, how patients can understand how their data are used, etc. And we would love additional help with this committee. And so if anybody is interested in being involved, we would really love for you to reach out to me, and we can get you in touch with the folks running the LEAP committee. There's no size limit on that committee, and the more people, the better. Thank you.
Okay, thank you very much. Now I'd like to move to our final panelist, Dr. Roberta Ortiz, who is based in Geneva, WHO HQ, to comment on how this relates to the Global Initiative for Childhood Cancer and all the work she's leading globally for WHO. To make improvements around the world.
Thank you for this opportunity. I know I only have less than 1 minute because we're at the top of the hour, but I just want to emphasize what has been said here. We know that robust health information systems are essential for cancer control planning and monitoring the performance of these programs to provide quality services for children as one of the objectives of this initiative. and very important to support priority and health-related decision-making. So through GICC, we have demonstrated that through a very strong multi-sectorial collaboration involving governments, UN agencies, as you have seen here today, IARC, our sister agencies, IARC, IAEA, professional organizations, and academia, as well as patients and families groups, we are able to improve outcomes through the implementation of the CURAL 4-pillar evaluation and monitoring, helping member states to improve their health information systems, as it was showcased through the presentation of my colleague from IARC, Eva. Very importantly, the need to strengthen the linkages between these population-based cancer registries and the surveillance systems that are being strengthening at the facility level through collaborations as with St. Jude Children's Research Hospital, through the support to facility-based information systems. It's also very important to understand, as it was highlighted by our colleagues from the Science Division, we are at a very important momentum where member states have mandated WHO to produce a global status report on cancer to stocktake on the progress achieved in overall cancer prevention and control, with a specific focus on childhood cancer. So having the opportunities of these partnerships to promote data sharing and research is fundamental to inform the actual status or baseline of childhood cancer burden of disease. That is fundamental also to advance the agenda or where we want to go towards 2030 to achieve the targets of the GICC. So I'm really grateful again for all your efforts. It's really inspiring to see the work across different networks, and we encourage to continue to doing this. And particularly this last question, as you have known, a very important aspect of our agenda is to meaningfully engage people living affected by cancer or people with a lived experience. So we congratulate the efforts of Sam and his colleagues on moving forward and giving also the voices of the people affected by cancer to help shape policy, but also research. So thank you very much.
And thank you, Roberta. And of course, this gathering of information for the global cancer status report to be published next year is very important, I think. And I hope that every country will work with you to get their best possible data on display. Okay, well, I thank you to all the speakers and the panelists for this fabulous overview of what's going on globally with clinical and epidemiology data for children and young people with cancer. I think this is the way forward. There's lots of strengthening efforts, and I hope that gradually we'll see the technologies available will be able to be spread more widely, and we'll have better information about the barriers to improving survival worldwide. So together we move forward. Thank you very much. I think our president, Guillermo Chantado, was hoping to be here, but I know he's also on service or maybe traveling. I can't see him. He was going to say a few final words, so I'll say them on his behalf. SIOP is, really delighted to be a partner and use the platform of London Global Cancer Week to share information in this way. And we ask all the attendees who are here, if you have ideas for future webinars in this week-long focus on cancer globally for next year, we'd be delighted to hear from you. You can email the SIOP Secretariat with your thoughts, and we will be writing to you to ask for your feedback on today's session. So thank you again to all the speakers and attendees, and we look forward to seeing you later in the week. We have another session on Wednesday afternoon, London time, on the global mapping project that SIOP has led the coordination of. Thank you very much. And goodbye. And no doubt see you, many of you, soon online or in person. Okay, thanks again.